It's a pleasure to be here this morning. Again, I'd like to thank the organizers. Hard to follow a charismatic speaker, humorist like Jim there, but I'll do my best. Also, I'd like to thank Jay Raymond, Dr. Raymond, for inviting me. He's an alumnus of our program, and when Jay called and said, "Look, can you do this?" I said, "Of course." So again, it's great to share the stage today with the renowned speakers, as mentioned earlier. So my talk differs a little bit from what you have in your slides. I had to do this a little more last minute with a focus more on active surveillance, but the goals during this little under 45-minute talk is to review epidemiology of prostate cancer very briefly. You know, why do we even look for prostate cancer? I think we have to remind ourselves of that. What's the rationale for active surveillance? We'll talk a little bit about biomarkers for appropriate risk stratification. And then, of course, the increasing role of MRI and MRI-targeted biopsies, as well as, I think, what we may call a more proactive active surveillance in terms of focal therapy or partial gland ablation. So in terms of the epidemiology of prostate cancer, it's interesting because when you looked at these numbers a little while back, for instance, just 6 or 7 years ago, the incidence of prostate cancer, that is new cases per year, was hovering around 230,000 men. And so we can see that there's been a shift to a lower number of men diagnosed with prostate cancer, which, as we'll see, may be a good thing. I also note here that number has increased, the incidence in 2018, as you can see, relative to 2017. The lifetime risk of diagnosis accordingly used to be 1 in 6, now it's 1 in 9. And you see here as well that the death rate, the mortality, actually is projected to increase this year relative to last. And there may be some reasons behind that as well. And of course, we know the prevalence is probably, this figure is from several years ago, so I would bet it approaches exceeding 3 million men now in the U.S. So this comes from Dr. Welch, who, if you guys read the New York Times, has recently had some controversy of his own in terms of, well, there's been a lot of controversy, I should say, about medicine in the New York Times recently, but there's something about plagiarism and so forth. But it didn't have to do with this figure, and I'm not so sure it's such a clear story there. But be that as it may, I think he's a great health policy maker or researcher, and he showed this nice figure about the decrease in the likelihood of metastatic disease, the incidence of metastatic disease at diagnosis after the introduction of PSA there in the blue on the left, relative to the introduction of mammography. And you can see that the likelihood of metastasis at diagnosis decreased significantly, and this is attributed to more of a Halsted approach of perhaps spread of prostate cancer. That is a stepwise spread from the primary or the prostate to the lymph nodes and then distant disease, whereas the constant metastasis diagnosis rate, despite the introduction of mammography screening, is attributed to a Bernie Fisher model of cancer in which there was already distant metastasis by the time it was diagnosed. Increasingly, and I think Jim hit this on the head, I think some of the apathy of men may speak to why prostate cancer isn't, or prostate cancer screening isn't as well heralded as, say, breast cancer or even screening mammographies, despite this statistic. On the right-hand side, you can see the ideal approach to screening. One is able to capture these bears or hummingbirds, and there's two smaller dashed lines here on the figure. Let's see if I can get there. This is at the point at which the disease causes symptoms, and that dashed line above it is the point at which disease causes death. And so certainly with screening, you want to avoid diagnosing these turtles or these snails. That is, you're just causing cancer anxiety. Treatments may cause decreased quality of life. Whereas those disease processes are never going to impact symptoms or even mortality. And then, of course, the hummingbirds are the analogy of the breast cancers that mammography isn't capturing. The bears are the ones that we can actually make a difference in terms of finding the cancer and curing these before they cause symptoms or mortality. Paralleling that decrease in prostate cancer metastasis at diagnosis is also the decline in deaths, which we see has steadily decreased until at least this year that's projected to increase. And you can see as well that screening early on, there was a large unscreened population in the early 1990s, and then as PSA testing became more frequent, that is almost even annually, then you could see the incidence went down as we picked out those men with prostate cancer. However, I think a lot of people started asking the question, is PSA really, is originally FDA approved as a biomarker for detecting cancer recurrence? Those of you who've been treated for prostate cancer recognize that value. After surgery, it should be undetectable. After radiation, it should decline, or nadir plus 2 or 3 successive rises. And also, we know in response to chemotherapy and ADT, which Dr. Keibel is going to address later. However, you had in this New York Times article the inventor of PSA at Roswell Park coming out and saying, I made a mistake. PSA is being used for screening. It doesn't help. And this was also substantiated by the American study, the prostate, lung, colorectal, ovarian study, which randomized about 70,000 men to annual PSA screening versus not, and then looked at its impact on prostate cancer-specific mortality. So it was a negative, showing PSA wasn't helpful. The European study, on the other hand, showed a decline in prostate cancer-specific mortality, but it was quite burdensome, meaning that you had to screen a lot of men, 1,400, treat 48, to prevent one death at 9 years, the original publication follow-up. However, we've seen these numbers come down with time. But confronted with this evidence, the U.S. Preventative Services Task Force, in 2012 said that there's no benefit to PSA. There's a high certainty that there's no net benefit. The harms outweigh the benefits. And so one of the research questions that we asked, we went back when the PLCO study became publicly available for secondary analyses. We looked closer at the study design. And this was the original study design, as I mentioned earlier. Over the course of 6 years, men were randomized to annual PSA screening, digital rectal exams for 4 years. And so again, when we saw publications, I think the pretreatment contamination was noted to be about 45%, and contamination, that is, men in the control arm who shouldn't have gotten PSAs, was noted to about half of them did. And so then we asked the question, well, how was contamination defined? And actually, what they did was they sampled a small number of small proportion of the men in the control arm. They had to answer the survey, and you can see here, if you checked off these boxes, you were said to have a PSA test in the control arm. And so therefore, if you answered that you had a PSA beyond a year, 1 to 2 years, 2 to 3 years, and it was for follow-up to a previous health problem or as part of a routine physical exam, it was not considered a PSA test. However, if you went back and then you checked off all of those, you considered those actual PSA tests to be true screenings or use of the test, we found at least that the contamination rate in the control arm approached 85% during the study, and even 90% at the end of the 13-year follow-up. And so I think this led to more and more people to realize that this was, I think people used to say it was opportunistic screening in terms of the control arm versus annual screening. However, the goal of a randomized trial, as people know, is to compare apples to oranges, and I'd argue that this study really compared apples to apples. I think furthermore, if we're using a survey to define contamination, we know that recall bias, that is, people tend to forget whether or not they had the test, and in other studies they've shown that men tend to underreport whether they had a PSA test in the past. And Ruth Etzioni, who's a biostatistician at the Fred Hutch at University of Washington, basically statistically modeled that contamination rate in the control arm, and then found that if you were to do that, that really the benefit of PSA testing in both the European study as well as the ERSPC and the U.S. study was actually pretty similar, and therefore reconciled the difference in those two findings. Certainly, we've seen a decrease in PSA testing, as noted by the decrease in incidence of prostate cancer. We then looked at the SEER database and showed that, at least in terms of distant metastasis, and that's been defined in the same way, that there was an inflection point in the sense that in 2012, the incidence of distant metastasis, as I showed you earlier, it came down nicely with the advent of PSA. Well, there was an inflection point. It started going in the other direction. And we actually just recently submitted another paper that shows that when you compare 2015 to 2014 in terms of incidence ratio, that continues to be statistically significant. Certainly, earlier this year, actually, in May 2016, the Preventative Services Task Force reevaluated the evidence. Instead of a grade D recommendation, which persists for men over the age of 70. Now for men less than 70 years, it's a individual treatment or individual option that is a grade C. And I think, as Peter Carroll noted, because the chair of the task force is now at UCSF, he mentioned recently that they had shown him a copy of the draft recommendation before it became positive. And one of the reasons why the task force backed off of its grade D is because of the uptake of active surveillance. And I think this was a nice study that was published several years ago. Many of you are probably familiar with the PROTECT study, which randomized men to what they called active monitoring, the radiation therapy as well as surgery. And basically you can see that at 10 years of follow-up in the top diagram, the prostate cancer-specific survival, very few men died of prostate cancer during this time. And I should mention that 3/4 of the men in the study had low-risk features, that is Gleason 6 prostate cancer. So this is a largely low-risk cohort. And then in terms of metastasis, the likelihood of metastasis at 10 years was about 6% for those who originally started with active monitoring versus 2 to 3% in those who had radiation or surgery. And so again, showing that the outcomes of active surveillance are relatively good. However, also noted in that study is that about 60% of men initially assigned to active monitoring had crossed over to definitive therapy at the end of the 10-year study period. Now, one of the things, being in New York now, I think a couple of years ago when maybe the uptake was a little less clear of active surveillance, one of the things that I would show patients is they'd come in, they have low-risk disease, and I just, we have, of course, like all centers do, have a computer in the exam room, and I would just go on the internet and say, why don't you take a look at this? And because if it's in the New York Times, it must be true. And basically, from a couple of years ago, this study mentioned that over half of men in the U.S. now diagnosed with prostate cancer are not choosing definitive therapy. And so, it's interesting when you look at the message being sent here. There's a guy leaning back on his muscular athletic red sports car saying that active monitoring is a manly thing to do. More recently, Stacy Loeb looked at nationwide data from the Veterans Administration hospitals and showed, and this is stratified by men aged less than the age of 65 versus greater, but you can see that there's been a pretty uniform uptake of both active surveillance as well as watchful waiting. And earlier that was a good humorous anecdote. And so we have transitioned more to active surveillance, which is monitoring with curative intent, whereas watchful waiting, as we know, is really not doing any monitoring, but really just treating symptoms once they become present. And so one can see that the combination of active surveillance and watchful waiting really exceeds 70% now in a system in which there's no financial incentives to treat patients. I mentioned earlier about image guidance and how this is affecting risk stratification and patient selection for not only for active surveillance but also for helping with treatment planning. So one of the controversies, at least in our field, is, and I saw one of the targeted biopsy device manufacturers outside, is can you do cognitive fusion versus software targeting? This is just a diagram where one can look at an MRI, draw out where the lesion is, and then use a transrectal ultrasound to try to hit that area. In contrast, there's software hardware platforms. This is actually what's outside the Artemis system, which uses a mechanical arm for proprioception of where that transrectal ultrasound probe is, and then superimposes, as you see in the lower right corner, the MRI image so that one can do a targeted biopsy. Todd's from the University of Michigan, and I have to give a shout out to two of my close friends, Ganesh Palpatu and Lenny Marks. And so this was a nice study where Lenny had a series of, I believe, 32 men who were on active surveillance, sent the tissue where they had active surveillance biopsies at least a year apart to Ganesh and the team at the University of Michigan to do next generation sequencing, but basically just showed that by looking at ERG immunohistochemical staining, that 96% of the patients who had serial biopsies, that they were able to hit the same clone of cancer. And interestingly enough, in those men who had a good RNA to look at this, about almost a third of men were found to have Gleason 3 + 4 = 7 on the subsequent biopsy. So showing again that some of these low-risk cancers at least have different behaviors in terms of genomic profiles, but also that there is progression potentially on active surveillance. A recent study, at least again looking at diagnosis and risk stratification, of course, is the PROTECT study, and this was a randomized trial, international study where men were with an elevated PSA were randomized to either MRI targeted biopsy alone versus a transrectal ultrasound biopsy. So one can see that of the 250 men in the left column, you can see in the third row there that 28% of men avoided a biopsy because they had a PIRADS 1 or 2, and those are, it's scored on a scale of 1 to 5. 1s and 2s are not suspicious for prostate cancer. The men with PIRADS 3, 4s, and 5s got a biopsy, and you can see here that the likelihood of finding clinically significant prostate cancer was 38% in the targeted biopsy group versus 26% in the ultrasound only biopsy group. And so this was really the first level 1 evidence that there's greater detection of clinically significant prostate cancer with MRI targeted biopsies, and 28% of men could avoid biopsies. However, I think there needs to be longer follow-up to really follow these men with MRI negative and therefore avoided biopsies to see what happens in that group. And also, from a public health perspective, this recently came out in press. When you look at the cost, and there's been other studies by Rosenkrantz from NYU and Chris Filson that estimates currently about 10 to 15% of men in the United States get an MRI targeted biopsy for an elevated PSA, and much of that is due to the payers, the insurers, not paying for that MRI in this elevated PSA setting. And although we're all advocates of prostate cancer and prostate cancer screening, I think we also have to be cognizant that we're looking at the same pool of money to treat various different conditions, including conditions of men with advanced prostate cancer. And so when we look at MRIs, the cost range from $650 to $2,550. It's estimated that 1 million prostate biopsies are performed annually, and we know that for men with active surveillance, for instance, perhaps there's MRIs that are being ordered annually in front of a confirmatory biopsy or to determine the need for a confirmatory biopsy. And we can see that if you scale that up, at least on the high end, MRIs before every elevated PSA can contribute $3 billion to healthcare costs, or if you take a fifth of that, certainly that's still about $600 million. On the other hand, if we adopt this wholesale, we know there's a limited experience of MRIs in some settings. For instance, 30% of community hospitals perform prostate MRIs, and there's a relatively low volume. I think more so, Jeff Sahn showed recently at Stanford that even amongst men with PIRADS 5s that underwent prostate biopsy, that the likelihood of finding clinically significant prostate cancer ranged from 40 to 80%, so therefore demonstrating heterogeneity, difference in experience of radiologists, as well as perhaps learning curve issues of doing the biopsy itself. So one of the questions we recently asked, if someone has multiple regions of interest, that is PIRADS 3s or higher, does that independently increase their risk of being diagnosed with prostate cancer? And when we modeled this in a multivariable regression, we found that number of lesions was not associated with a synergistic effect of an increased risk of finding clinically significant prostate cancer. The other important thing about a targeted biopsy that one needs to think about is that in the precision study, the randomization was for target of the region of interest alone versus just a trust biopsy. So I think that differs a little bit from how most of us do a MRI fusion-guided biopsy. I think we continue to do a target biopsy, that is the MRI abnormal area, as well as the region of interest. And so in this study, we're able to go back and really track each of the Artemis biopsy needles, and this just shows you the figure that the computer software captures and saves. This is just a representation of this particular gentleman who his region of interest, you can see there, really comprises the entire right lobe of the prostate extending across the midline. And so in this particular person, there's a lot of overlap between the systematic and the targeted biopsy. The systematic biopsies on the right side would have hit this region of interest. And so when we went back and we looked at 240 men, we found that on average the median number of systematic cores that would hit a region of interest was actually about 1 of those biopsies. And so then when we compared the targeted biopsy acquisition there in the rows versus the systematic scores of the biopsies obtained in that fashion, we found that if we the targeted biopsies would have only missed 3% of clinically significant cancers, and the upgrading of the systematic biopsy was only about 6%. Now, this is with Dan Margolis, of course, who's on the PIRADS committee, looking at most of our MRIs and also doing all of our segmentations for the targeted biopsies. And also with the caveat that when we look at the learning curve, at least my own personal learning curve for doing a targeted biopsy, and we split this cohort of 173 men into tertiles, and we looked at accuracy using this mathematical modeling where we could track the trajectory of the core relative to the region of interest. We looked at the distance of the tip from the region of interest and therefore described that mean distance from the region of interest. And in the top column, you can see that initially in the first tertile, on average, we were about 6 millimeters away from the target, and that decreased over time to 0.06. And so showing, and also with the systematic biopsies, because the Artemis, if you don't look at the real-time ultrasound, you go out too far to the side, it's very easy to get fibromuscular tissue not to hit the prostate at all. And over time, we can see in the bottom table that the amount of prostate sampled as well as the avoidance of fibromuscular tissue increased over these 100 patients. And so I think those are the caveats that one has to keep in mind when you talk about generalizing level 1 evidence to the population. That is the significant learning curves of the radiologist as well as the urologist in doing these targeted biopsies. Switching gears now to focus more on active surveillance. This is a very nice review paper that just came out from European Urology and very nicely summarizes candidacy for active surveillance. I think the key points here is that there's very little data for younger men, those that are less than 65 with a long life expectancy about really long-term follow-up, and again, making those men aware that there's limited data to look at these outcomes beyond the median follow-up of 6 or 7 years in some of these active surveillance series. Moreover, we know that African American men in the United States are more likely to be diagnosed with aggressive prostate cancers, higher prostate cancer-specific mortality. However, a lot of the active surveillance series, I think as recognized in the U.S. Preventive Service Task Force recommendations, even there's an evidence gap in knowing by race what the implications of active surveillance long-term are. Now, I think the NCCN very nicely parallels some of those, that initial slide. You can see here that men with a low risk, and also they stratify as very low risk, which just means lower tumor volume, gives you the paradigm of saying observation, of course, for less than 10 years of life expectancy. For those with greater than or equal to 10 years, they can be counseled about initial treatments of definitive therapy, surgery, radiation, as well as external beam radiation brachytherapy. This is a figure that just summarizes, as I mentioned, some of the parameters for enrolling men to various active surveillance series internationally. And you can see that there's quite a bit of heterogeneity in terms of enrollment criteria, but also B, that there's also very few centers that have enrolled men with pattern 4 on the biopsies, or at least in grade group 2s or higher. And so the recommendation from this EAU paper was that, again, that the evidence is still unclear long-term about what these outcomes are, and really cautioned urologists and providers from enrolling men with 3 + 4 = 7, because it's clear that these men have an increased risk of clinical progression, development of metastasis, and if they go on to surveillance, they really need to have a standardized protocol. It's interesting, the contrast here, you can see again for the NCCN, there's more of a acceptability, if you will, for looking at active surveillance or observation, particularly for men with less than 10-year life expectancy. And that's actually even noted there at the bottom for those with unfavorable intermediate risk, that is Gleason 4 + 3 = 7 or grade group 3. So when we speak about the percent pattern 4, because that's something that ISUP, or the International Society of Urologic Pathologists, have recently started quantifying, and our pathologists do, and I've seen a lot on the outside reports do that as well. But I think one of the reasons is, and a nice thing to review to keep this in perspective, is a study that came out of the Martini Clinic. And so this is a high-volume radical prostatectomy center in Germany, and you can see this is a cohort of 12,000 men who underwent radical prostatectomy for whom they had biochemical recurrence data. And this is a busy slide, but basically the takeaway message here is that they looked at quantifying the percent of pattern 4 and then relative to Gleason 9s and 10s and 8s there at the bottom. But essentially, when you look at the proportion of pattern 5, for instance, the men in the second line here is 5% Gleason pattern 4, so 3 plus 4 with 5%. You can see that the proportion of pattern 4 really predicts very well here the amount of the likelihood of biochemical recurrence. And so I think that's one thing to keep in mind when we look at biomarkers and so forth, or even get a pathology report. If someone had a pretty good sampling of their tumor, the percent pattern 4 is a pretty good predictor for the aggressiveness of that cancer, and that the men with lower percent pattern 4, that is 10%, 5%, the behavior of their tumors really mirrored more closely low risk Gleason 6 prostate cancer. When we talk about longer term active surveillance, I think we have to look at the Sunnybrook experience from Toronto. Klotz and colleagues here looked at the difference between looking at the metastasis-free survival for those with Gleason score 7s and compared that to those with PSA 10s greater than 10. And here you can see that the Gleason grade really predicted the likelihood of metastasis more stronger than the PSA. And at 90 years, there's 90% metastasis-free survival at 5 years, 85% at 10 years for those who had intermediate risk prostate cancer. And then when you look at the hazard ratios for metastasis-free survival, cancer-specific as well as treatment-free survival, again, as mentioned earlier in that EAU slide about cautioning about active surveillance for intermediate risk disease, you can see that the likelihood, the hazard ratio for intermediate risk disease is at least threefold higher for metastasis as well as cancer-specific survival. Or the flip side of that is the development of metastasis or mortality. And subsequently, this again looks at treatment-free survival as a curve. And then when you break down the intermediates into those with 4+3 favorable versus unfavorable here at the bottom in C and D, you can really see a separation that happens with unfavorable intermediate risk disease in terms of metastasis-free survival. There's a 2% metastasis rate for the 3+4 = 7s. At 10 and 15 years, it's 92% and 82%, whereas for the unfavorable intermediate risk disease, you see 5% metastasis at 5 years. And interestingly enough, as I mentioned earlier about PSA, there's overlap between the men with low risk PSAs less than 10 versus a Gleason 6 PSA 10 to 20. And so just going back to the MRI story, the recommendation, at least by the EAU, is that a multiparametric MRI should be performed before a confirmatory biopsy is done within 12 months of the initial diagnosis. We can't skip the systematic biopsies yet. We just know very little about what the implications of skipping that is. I think it's also a good idea to include that given the learning curve for targeted biopsies, as we talked about earlier. Even if there's a negative multiparametric MRI for men on active surveillance, a systematic biopsy, that is typically 12 biopsies, should still be spread out throughout the prostate. And if an MRI study is deemed of insufficient quality, it should be repeated before the confirmatory biopsy. Just an example of that, this was a series that I wrote up. Actually, these were all Lenny Marks patients when I was back at UCLA. These were men who had had an outside or a conventional biopsy that came to see him. And then at the time, UCLA wasn't using PIRADS, but we looked at the original Epstein criteria, which one can question, does that really even apply now? The low-risk Gleason 6s, do they really behave differently? But we looked at the likelihood of reclassification, and you can see here this was high-volume disease, and Gleason 7 would be the black. Gleason 7 alone was the gray, and then high-volume 6s. But certainly there's a strong correlation between a greater suspicion on MRI and the likelihood of reclassification beyond low-risk cancer on a confirmatory biopsy. I'll just touch upon, I think, an increasingly important trend that urologists are going to see in the next couple of years. That is in-office transperineal biopsies. We know that the likelihood of infections is increasing, particularly in those who are exposed to healthcare workers or those who've been hospitalized within the past 6 months. That likelihood of infection now is estimated to be about 7%. Likelihood of hospitalization after a prostate biopsy is about 1 to 2%. The risk of death after a biopsy is about 1 out of 1,000. And so the transperineal approach, actually, you're using an ultrasound probe in the rectum to visualize the prostate, but you're going percutaneously between the scrotum and the rectum. In fact, the interventional radiologists in their guidelines argue that you don't need any prophylactic antibiotics if you're doing percutaneous procedures, and we know from the literature that more and more urologists are adopting an augmented prophylaxis, that is, giving dual or antibiotics before a biopsy to prevent infection. Therefore, again, I think that increases antimicrobial resistance, and for antibiotic stewardship, we can look at this, for instance, as a potential way to decrease that risk of infection. Moreover, as noted by Ted Schaefer and others, African American men are more likely to have anterior prostate tumors, and a transperineal approach does better, certainly gets better sampling of anterior tumors, as you've seen from this figure. And in men with larger prostates, when you approach these from the rectum, of course, a typical biopsy needle traverses about 2 centimeters, and so you can see that you're going to miss a large portion of the anterior part of the prostate. I think more so as well for certainly we can resort to this, and I think many urologists do, to saturation biopsies if men have prior negative biopsies, but with a very nice local block. This is being done increasingly in the office. The challenge of doing transperineal biopsies, a targeted biopsy in the office setting, there's no CPT code. The 55706 applies to a saturation biopsy. These also, on average, take longer than a transrectal targeted biopsy, and I think there's a lot of improvements that are going to be coming down the road regardless of which platform is used. I'll just briefly touch upon biomarkers for active surveillance. This was a Wall Street Journal article that came out recently that really talked about some of the biomarkers that are out. And the EAU review that I mentioned, this is their statement, which is that there's a PSA isoforms, PCA3, TemperSurg, 4K, GPS that shows some promise. However, there's an absence of robust prospective testing that prevents its recommendation of these biomarkers in active surveillance. And this is a paper that just came out in press, I think, which very nicely answers the question, or at least compares the use of MRI, which we talked about earlier, with biomarkers coming out of UCSF. This is the cohort of their active surveillance series. They looked at men who had both a GPS score, the Oncotype DX, as well as the PIRADS MRI study. And in the multivariable analysis, it's interesting that the GPS score, every 5-unit increase, and that goes from 0 to 100, was significant in predicting upgrade on a subsequent biopsy within 3 years. Relative to, you can see that the PIRAD scoring on an MRI wasn't significant. The PSA density at diagnosis approached significance with a p-value of 0.07. So at least arguing that a GPS score has an increased prognostic ability for predicting upgrade. When you look at the waterfall plot here, the blue just represents these are patients, individual patients on the x-axis. On the y-axis, it's the GPS score. And so again, just showing that as you get to the right side where there's upgrade, more likely to be upgrade in blue, there were the higher GPS scores as well. In terms of active surveillance follow-up, I think at present this is what most people are doing. You're doing a serial digital rectal exam at least once a year, a PSA every 6 months, the minimum interval of repeating a biopsy 3 to 5 years, and again, the MRI cannot be used as a standalone tool to trigger follow-up biopsies, but I think that we're going to start seeing more prospective data in terms of potentially spacing out biopsies based on MRIs or the biomarkers. In terms of, I just note here, when you look at these various published series, in the right-hand column, very briefly, you can see that there is a lot of heterogeneity in terms of how follow-up was done. In terms of a psychosocial aspect of active surveillance, patient distress should not trigger radical treatment. There's also a role for having these men get psychosocial, psycho-oncological support. We recently hired a psycho-oncologist for this and other cancer anxiety issues. And at least in Klotz's Sunnybrook series, patient preference accounted for 6% of men discontinuing active surveillance. Triggers to cease active surveillance, certainly grade progression as we've discussed. I put tumor volume question mark. It was mentioned in this in this study. However, I think when you look at that Martini Clinic data of percent pattern 4, I certainly have men with high volume Gleason 6s on active surveillance. And then again, they advocate converting to watchful waiting when life expectancy is 10 years. I think a practical takeaway, again, is the PRIA study. This is a 18-country, over 5,000 men cohort of men on active surveillance, and this just tells you the reasons that they discontinued active surveillance, with up to 10 years of follow-up. The majority of these men in green discontinued active surveillance because of these parameters, such as a shorter PSA doubling time or higher tumor volume, upgrading. And you can see on the bottom that some men discontinued. There were some men that were lost to follow-up, which is critical to make sure that doesn't happen, as well as others who, because of anxiety, converted to definitive therapy. But then when they modeled the predictors of finding unfavorable disease, that is unfavorable intermediate risk prostate cancer or T3 disease at radical prostatectomy, you can see that the only factor here was Gleason greater than 6 on the last biopsy. So arguing that age, the PSA density, the doubling time, so forth, the number of positive cores or tumor volume should not be triggers to take someone off of active surveillance. Now, one may ask the question, well, how expensive is active surveillance? Shouldn't we just be treating these men up front? Michael Porter from Harvard Business School really defined value as the health outcomes over the dollars spent. And UCLA had embraced this approach when I was there, and I was fortunate to work with Chris Seigel and Aaron Laviana looking at time-driven activities-based costing, which comes from the business world. This is where you look at a process map, you look at how long per unit time it takes for each of these steps, and then multiply by, derive a rate and multiply the cost per unit step. This is just an example of HDR brachytherapy, breaking that process down individually and looking at the costing that happens at each step. The takeaway message here is that when you look at 5 years of cost at least, active surveillance does fairly well. TDABC is looking at real costs. It's not charges. It's not what the Medicare or the payer reimburses. And you can see that the 5-year cost for active surveillance would be about $7,300. IMRT on the other end of the spectrum would be about $2,400. Now, when you throw in an annual MRI for about $600, that's going to tip the scales a little bit, but it's still going to stay on the low end. Very briefly, I'm just going to talk a little bit about what I termed proactive active surveillance or partial gland ablation. There are focalists, if you will, out there who are treating the unfavorable or the 3 + 4 = 7s. They're not treating the 3 + 3 = 6s to try to convert these intermediate and favorable and unfavorable guys to low-risk prostate cancer. This just is a schematic demonstrating the various forms of energy. This was all brought on by the FDA in 2015, really listening to the patient voice and the patient advocates. This is really something that patients wanted, and you can see here that the patient advocate mentioned that if you had the ability to treat part of the prostate, the analogy of a partial mastectomy, it'd be like a promise from heaven. Men really dread these biopsies. They'd much rather have a partial gland ablation. And this has been going on for some time. When you look at the COLD registry, you can see that in 2008, approximately 40% of the cryotherapies being done captured by this registry were partial gland ablations. This is how it's done percutaneously. I'm going to skip for the interest of time to get us back onto schedule, but using the same approach that we use for a targeted transperineal biopsy, you can actually percutaneously place these needles and do this in the office. And this is just a video abstract that we presented at the AUA. Let me see if I can play this very briefly here. And so this just shows at least a Artemis guided biopsy, and I'm sure the other platforms that are out there can do this. So again, this patient's awake. We can see the real-time ice ball as well as the overlay of the MRI targeting. So I think that's something that we're going to increasingly see given the direction of image-based diagnosis and now treatment. We argue for doing this responsibly. We are leading a partial gland ablation with the FDA. This is a coordinated registry network that now is Michael Gorin at Johns Hopkins that we're partnering with to really host this via REDCap and look at smartphones and apps to really capture patient-reported outcomes on a prospective level. And so I'll just summarize with this slide, which was was the visual abstract, if you will, from that review paper. This shows that, of course, men follow them up with PSAs, prostate exams, repeat biopsies, do an MRI before the confirmatory biopsy, but don't skip the systematics as of yet. Thanks for your attention.